Good morning, good afternoon, good evening, depending on where you're joining from. Welcome to today's webinar. This is the third chapter in our Knowing Your Assets Value series. Today, the topic is applying customer insights, and we will discuss the strategic question, what share of my target population will I achieve? My name is Jeff Olive. I'm the founder and CEO of P3i Consulting. Just a couple of quick logistics notes. Today's session is being recorded, and there will be time for Q&A at the end. So just a little bit about P3i and who we are and what we do. We specialize in using financial models to enable confident decision-making in spaces that range from BD&L to launch forecasting to P&Ls and long-range plans. We believe the benefits of working with us are that you'll receive a clearly articulated point of view on the economic value of clinical and commercial strategies. In terms of the services we offer, there's three core pillars. One is obviously financial modeling. The second pillar relates to analytics for managing uncertainty and portfolio prioritization. And then the third pillar is for services that can range from training to objective assessments to capabilities building and process design. Again, my name is Jeff Olive. I'm the founder and CEO of P3i. Before I founded P3i, I was at a biotech startup called EQRx. Some of the work that I did led to the informing of launch sequencing for our launch assets, as well as informing trial design for some products in the pipeline. Prior to that, I was at Merck for many, many years and had a leadership role in establishing Merck's global oncology forecasting capabilities, primarily for Keytruda, but there were many others, obviously. And we did that quite successfully with a fair degree of forecast accuracy. So moving on to today's strategic question, what share of my target population will I achieve? We'll talk about this subject in a couple of different webinar that are coming up, especially because it's such an important question when valuing an asset or doing a forecast. Today's topic, again, is the customer insight side of this, and we've prioritized that largely because of the large spend associated with doing conjoint studies. And so just to level set everybody, what is a conjoint study? You'll also hear these referred to as demand studies. So these are basically quantitative market research studies. And in these studies, we'll ask prescribers to make choices about how their prescribing would change if a hypothetical new product was available. And often these products are in phase 3 or going through a registrational clinical trial. And so the product profile is not fully known. And in these surveys, we can vary different product attributes to see how the market will respond to different outcomes from our clinical trial. A typical deliverable from these studies is obviously a comprehensive report, and you'll also get an Excel-based simulator. And that will allow you to toggle through different product profile assumptions and see how that changes the expected preference share. Many of these studies are designed in a way where you can do segmentation through attitudinal questions as well, which makes them even more powerful. So there's 4 types of conjoints that you'll typically see. The most common is the choice-based conjoint. In this type of conjoint, respondents are basically asked to make trade-offs between different product profiles. Typically, you'll see this done by varying like efficacy and safety attributes and seeing how they respond. There are also adaptive conjoints. Typically, these are executed when there's just too many choices to manage. It does offer the respondents a little bit of a customized experience as well because it adapts to their responses. The third type of conjoints, the full profile conjoint, and in that one, respondents are basically given a yes or no option as to whether they would prescribe or not. And then there's also max diff, which helps go through a prioritization and ranking exercise on a scale of best and worst. So these conjoints tend to be expensive studies and are very informative, packed with information, and extremely valuable. That said, they're not without challenges. And so let's just cover that in a little bit of depth here. Some of those challenges are that, in that market research setting, it's very difficult to simulate full knowledge of the product. Even the manufacturer doesn't have full knowledge of what the product would look like. So there's some missing information for respondents. But keep in mind, the products that are being tested offer to achieve satisfaction of an unmet need in the market. And so, physicians that have these unmet needs can be over exuberant and over respond. So you might get a little bit of bias in the survey. A third area that you have to be kind of watchful of is the baseline allocation of how products are prescribed today. Usually there's a section in these conjoints where physicians, prescribers will allocate to different products what they prescribe today. And almost invariably, those allocations diverge from reality. And so you'll have to think through how to potentially address that. Speaking of the allocation exercise, these are often executed by just a tabular ranking or allocation of shares to different products versus exposing the prescriber or the doctor to a patient profile that they can respond and say, yes, this patient would get this product. And I think in these allocation exercises, they're a little bit more abstract for respondents. In terms of product profiles, again, they're limited, they're not full PIs, and so there's a level of oversimplification in the material that's presented. And I think you'll also see it's very difficult to simulate order of entry, which we know is important in the biotech industry. So if you have multiple product profiles, say for you or a competitor, it's very difficult to simulate that. Not that it can't be done, but it's imperfect, obviously. And of course, it's in the research environment, so there's no promotional or counter-promotional messaging taking place either. So some pitfalls that you'll definitely want to be aware of. Some specialists do refer out. And so if for the particular disease that you're studying, that's a dynamic that happens, you'll obviously want to be aware of it and potentially exclude doctors that refer out because they are not the decision makers in those cases. Sometimes there's a temptation to show price in these studies as well. And particularly for many physicians, it's not really a factor. Maybe copay in the US, for example, could be relevant. But generally, we would recommend not testing attributes that are of either low importance or low awareness to respondents. The other thing that can happen is, remember, these assets are in development, and the research labs might have a particular perspective on what a range of outcomes could be. And sometimes those ranges are a little narrow. And if you confine yourself to a narrow range, then if for whatever reason the trial comes out beyond those ranges, it's tough to apply the research. So it's good to have the range from your research colleagues, but we always recommend testing beyond that, just in case something surprising occurs from the clinical trial. So we'll spend just a little bit more time talking about how conjoints are executed and start introducing a concept that's important to me, which is, while these are great informational studies, bear in mind, they're not 100% precise. And so having an ability to think through what ranges could be is also important. So how are these conjoints executed? Again, they're online surveys typically. usually there is a target list of prescribers that the manufacturer would choose. Typically, they're higher decile prescribers, so potentially some bias there. And usually they have to meet other screening criteria as well. As I mentioned before, these conjoints will typically start with an exercise where physicians allocate share for products they currently prescribe for a given therapeutic area. Then they'll see the product profile that's being developed, and then they'll have the opportunity to allocate share to the new product. And they will do this multiple times. And typically, I'll say maybe 5 to 10 times, they'll see different product profiles where these attributes are tweaked a little bit from one scenario to another. And then that gives us, on the manufacturer side or the consulting side, information about which attributes are most important. So if you take a very simple example, for here I have product X, we have three kind of classic attributes that would be studied: efficacy, safety, dosing. And again, we don't really know what's going to happen in our clinical trial, so there's different levels that we would test. So for efficacy, anywhere from a 10% improvement versus the standard of care, all the way to a 30% improvement. And we do obviously similar for safety and dosing. This is all very illustrative. But you'll see we have kind of two scenarios that are laid out here, one with red circles and another with green. And so in the red circle scenario, we have a product profile that you can see is pretty much almost the worst case. But there is a little bit of a benefit versus the green scenario on the safety. So the green scenario has advantages in efficacy and dosing, but a disadvantage in safety. And so how do prescribers think through those choices? And so on the right, what you'll see is I've given, again, just a very illustrative allocation table. So again, before product X is available, we'll get that baseline allocation. You'll see I've made it very simple between the standard of care and all other products they would prescribe. It's the 80-20 rule. And after product X is introduced, you'll see product X gets a 30% share. As you can see, this is kind of difficult to do for a physician, right? You have a little bit of information about the product, but can you really say I'm going to give that to 30% of my patients without visualizing all of them? And I know this is, kind of framed in a way that it should be done on average, but I think this is, a little bit of an abstract exercise. And I think we should keep that in mind for people receiving these studies. And just to make it a little bit more tangible, things to consider, right? If somebody asked you or me to decide what percent of our dessert budget, for example, would go to something that was 20% tastier but 10% more fattening, how accurate of a response can you really give to that type of question? Maybe there's more information you need. Maybe you'd want to sample. Obviously, we can't sample in pharmaceutical research, but you get the point. The other thing I'd say is all of these allocations are typically made in 5 to 10% increments, right? There's not that much precision collecting these data. And so bear that in mind, is right off the bat, there's probably about a 5 or 10 point confidence interval just in the way the data are collected. And so that's the key takeaway, is conjoints are really powerful, but for all of the reasons I've mentioned, I just want you to keep in mind that there's some uncertainty, and try not to think so much of your conjoint as being a specific number and more of what's the range of possibilities that the research would support. And so to that end, and the point I was making to my kind of, almost ridiculous dessert example, do people always do what they say they will? And the answer to that question is no. It's been proven in multiple studies. So if you go back to my 30% preference share, the question becomes, well, how much do you dampen that by? And there's different ways to do this. Different market research firms have different approaches, but they tend to do it. So check with them, ask how they do it, and make sure they're doing it. two common implementations are primarily the Bayes method, but also the Juster scale, and probably everything in between. But the way the Bayes scale works is you ask a likelihood to prescribe question, and if somebody gives it a 5, for example, I would definitely use the product. What the dampening factor says is that even if they say 100% of the time I'll use product X, in reality, it's only going to be 75%. And as you can see, it just gets, more and more significant as you go through that 5-point scale. The way Bayes developed this was they actually did diary studies. So they would collect, these 5-point ratings, and then they basically did a regression analysis, and they made these correlations. And so there's data to support that. The Juster scale is very similar. Obviously, it's a little bit more fine-tuned. The point that I would make here is that regardless of, exactly the dampening method that you choose, it's obviously going to vary across industries. It probably varies a bit from one disease to another. It's not 100% perfect. The point is, again, we're trying to be within the realm of possibility here. The other comment that I would post here is I've seen some companies use both in conjunction, particularly when there are cultures that tend to be a little overly enthusiastic. You can maybe use the Juster scale as kind of a level of confidence to further fine tune that. And so questions you may want to think about as you get your research back: how much dampening occurred between the raw shares and the dampened shares? Was it closer to that 25%, maybe closer to the 25%? You'll want to see how confident people are in their responses. And what's that range? What's the distribution? Is it almost universal that people are 4 and 5s? Are you getting some 1s and 2s in there? That will also help you think through how much of a range you should put around your point estimate. So things you can do with the conjoint, and if you're a data geek like me, they might even be fun. One area is gauging that variability in responses. So kind of dovetailing off of what we just talked about, what is that overall distribution in responses? Is there any sort of central tendency to it, or is it more of just a flat, uniform distribution, which means perspectives are really diverse if it's uniform? If you are trying to get that perspective of central tendency, one of the things you can do is just look at the standard deviation. One standard deviation, if it's a normal distribution, is about a 68% confidence. So if you take that average and you put a roughly 70% confidence interval around that, you're very likely in the target range. So that's good. You could do 2 or 3 standard deviations. I think you'll get ranges that are probably too big at that point, but you could try. The other thing you could do if you want more than that 70% confidence interval, you could look at like the inner quartiles. That'll narrow it down to like a 50% range. But again, just different ways to look at the ranges for the scenarios you're evaluating. Second thing that you can do is look at the drivers of share. So if you think of that orange kind of bar on the worst case to the best case as a 100-yard field, we have the worst case at kind of the 0-yard line and the best case at the 100-yard line. If you only move the efficacy assumption, for example, from 10% to 30%, how many yards of that 100-yard field do you traverse? Do you go 20 yards, 50 yards, 80 yards? Same question for safety and dosing. That'll give you a sense of how important each attribute is. The other thing you can do is you could start looking at, if you've included attitudinal questions, you can include those in this type of analysis as well and see if any sort of segmentation might emerge. And so that's the third thing that you can do with this is if you've done this with some attitudinal questions, you can start thinking through which attitudes might correlate to certain shares. Maybe you have a target segment in mind. How does your target segment perform in this conjoint study? Can you simulate that? So lots of different things you can do with this conjoint study. And then the other thing that I would encourage you to do is to look at source of business. Most of the products that are coming out typically are for patients that are already receiving some treatment. It's very rare that, you're expanding a treatment rate or diagnosis rate, although that does happen, obviously. But these products are going to be used instead of something in most cases. And so what is the product being used instead of is kind of important to understand. So if you go back to my example of the kind of 60-10-30 scenario, product X gets a 30% share with basically 2/3 coming from this standard of care. So 20 of the 30 points comes from standard of care. The other 10 come from all others. So that translates to about 50% of all other business going away and about a quarter of the standard of care business going away. Questions that you may want to think through. If the standard of care could not penetrate the remaining 20% of the market, in other words, it didn't get 100%, it wasn't that much better. There are still patients that are appropriate for other medications 20% of the time. How easy is it going to be for you to displace that? So think about that. You're getting about a quarter of the standard of care's business, but 50% of all others. Why is that? Maybe there is a clinical reason. I don't, obviously this is a hypothetical example, but maybe your product has some sort of advantage and you're going to disproportionately target patients on these other products. That would be important. Or maybe if your target is in fact the standard of care, maybe that's a source of overstatement in this conjoint. And again, because of that allocation exercise, maybe there's some business that's being taken from all other that's probably a little too much, and you might want to think about dampening that. All right, so closing thoughts. Obviously, conjoints are powerful tools, but I think we have to acknowledge they have their limitations. Some of the limitations include just difficulty simulating a realistic prescribing environment. I think the other that we talked about is that allocations tend to be made in 5 or 10% increments. This makes it very difficult to test markets where there is a very small target population, maybe at a high end or low end of the spectrum. And so you'll want to think through that as well. And of course, we always need to dampen the preference share responses. Bottom line, conjoints will tell you the key drivers of your market share, and that's important for you to know. But you can also gauge variability in responses and assess range. You can use that to pressure test all of your sources of potential shares. You can pressure test against analogs. You can look at what advisory boards are saying, but take advantage of the opportunity to interrogate the data. Work in a team to build consensus on what that range is, where within that range you might want to place your bets for a discrete forecast, which is used for financial planning oftentimes. And also, if you do Monte Carlo analysis, just think of the work that you're doing to inform the distributions on your Monte Carlo simulation. We do have time for questions. If there's any questions, we'll pause here for a moment to ask a question. You'll see a Q&A bar at the top. Feel free to click that and key in a question if you have any. In the meantime, while we're waiting for questions, I have some that came in over email. I'll go through those in case we have time before any additional questions come in. So question number 1, can I glean insights about the role of different specialists? Yeah, absolutely. If you've invited to your survey different specialists, maybe in internal medicine, maybe cardiovascular doctor, maybe endocrinologist, whatever it is, yes, you could certainly parse out responses by specialist. And if you've included attitudinal questions, you could certainly try to develop different personas across the different types of specialty. And question number 2 that came in is, if my market research firm already dampened preference shares, would you apply any additional dampening? That's an interesting question. Again, I would try not to think of this as a point estimate, right? That needs further dampening or not. I think what we're trying to get to the point of is what's the realm of possibility that the survey would suggest. And if you're at the high end of the distribution, maybe that's a lower dampening. If you're at the lower end of the distribution, maybe that is a higher dampening. But I would kind of try to think of it in terms of likely ranges and what that realm of possibilities is. Okay. All right. It doesn't look like we're getting any other questions. So just to close out, we do have another session in the series, How to Work with Imperfect Analogs. Again, that's a great source of information to inform market penetration assumptions. The strategic question we'll continue to address there is, what share of my target population will I achieve? That is 2 weeks from today on September 28th. And of course, we have our parallel trading series, which is, more the analytical side of the webinar series. That's coming up next week. If you'd like to enroll in that, we have 2 options available to accommodate different time zones. That's September 20th and 21st. And there we'll talk about building future marketing landscapes. So we'd look forward to having all of you there as well. And so with that, we're pretty much at time, right on track here. Thank you for your participation, and we'll look forward to seeing you in our next webinar.